Today we are going to talk about the respiratory system, and we're going to start with a conversation about the anatomy of the respiratory system and its function. So function is to deliver oxygen to the blood and to expel carbon dioxide from the lungs, to humidify and filter the air that's coming into the lungs. It also aids in maintenance of blood pH, and it is absolutely important to produce the sound. There are two anatomical divisions to the respiratory system: upper respiratory tract, that consists of the nose, pharynx, and larynx. Upper respiratory tract warms the air, moistens it, and filters the particles out of the air as the air enters the body. Lower respiratory tract, that consists of trachea, bronchi, and lungs, participates mostly in a gas exchange between the blood and the environment. The nose has, turns out, multiple anatomical parts: dorsum nasi, ala, apex of the nose, philtrum under the nose. The function of the nose is to filter out the large particles. Hair in the nose do it. Mucus that is in the nasal passages allows to trap small particles and bacteria and prevent them from entering further. The epithelial covering in the nose is pseudostratified ciliated columnar epithelium, and cilia allow to move the mucus away from the lungs. Ciliated epithelium in the nose has some neurons, as you remember from our special senses chapter, that allow you to sense the smell. If you move from the nose further, you will enter pharynx. Pharynx can be separated into three parts: nasopharynx, oropharynx, and laryngopharynx. Nasopharynx, or upper throat, participates only in the respiratory activities, only in the breathing, and it is closed by the uvula when you swallow. Nasopharynx is connected to the middle ear by the Eustachian tube. These tubes open up to equalize air pressure between the middle ear and the outside world. Oropharynx, located posterior to the tongue, contains two tonsils, palatine and lingual, that are the first barrier in preventing infection. And laryngopharynx here opens towards the larynx and towards the esophagus. So basically, laryngopharynx has openings into the respiratory tract and digestive tract. Both oropharynx and laryngopharynx participate in both digestion and respiration. Larynx, or voice box, divides the upper and the lower respiratory tract. It is entirely composed of cartilage. Its function is to keep respiratory tract open. Also, the voice box, as you can guess, is responsible for this speech production. You can see the vocal cords here. So the cartilage that that forms the larynx is mostly thyroid cartilage. It forms Adam apple in front of the larynx. Now, respiratory passages, the larynx can be closed by epiglottis, the flap that covers larynx when we swallow, thus preventing food from entering the lungs. Cricoid cartilage in the posterior aspect of the larynx keeps the respiratory system open, and when you swallow, larynx moves up while closing epiglottis. Again, all of it is done to prevent the food from entering the lungs. Lower respiratory tract consists of trachea, bronchi, and lungs. You can see trachea, bronchi, and lungs. It moves air towards the respiratory membrane, and this part is still called a conducting zone. Physiologically, conducting zone consists of upper respiratory tract, trachea, and bronchi. When air gets into the respiratory zone, which consists of respiratory bronchioles and alveoli, it's deep in the lungs. So the function of conducting zone is to transfer the air from the atmosphere to the respiratory zone through the nose, pharynx, larynx, trachea, bronchi, bronchioles, and terminal bronchioles. Then air enters the respiratory bronchioles and alveoli, where gas exchange happens, and that's the respiratory zone. Now, trachea is the fairly large, pretty strong tube that connects larynx to the bronchi right here. The rings of cartilage prevent it from collapsing while people breathe. Also, trachea is quite elastic, which allows the esophagus to expand when we swallow. Carina, the lower base, contains very sensitive mucous membrane. When something touches that membrane, we start to cough. So, lower portion of conducting zone and respiratory zone are often called a bronchial tree. Trachea splits first into two primary bronchi here, right and left. Primary bronchi divide into the secondary bronchi. So right bronchus divides into three secondary or lobar bronchi, and the left bronchus splits into two secondary or lobar bronchi that supply different lobes of the lung. Tertiary bronchi, quaternary bronchi, then smaller bronchioles, and finally terminal bronchioles and respiratory bronchioles. Basically, bronchi keep on branching. As they branch, the cells, mucosal cells, becomes smaller. From columnar, they get to be more cuboidal. Cilia disappear, and their macrophages appear that remove dust and debris. When bronchioles become smaller, amount of cartilage decreases, and amount of smooth muscle found in the walls of bronchioles increases, which means that bronchioles can contract or dilate. Lungs are filling the rib cage. The base of the lungs sits on the diaphragm. The apex is slightly above the clavicles. Right lung is shorter but fatter. It has three lobes: superior, middle, and inferior lobe. Left lung is thinner, narrower, has two lobes, superior and inferior, and it also has a depression here called cardiac notch. So each lobe is a separate section of the lung, and lobes are, air gets into the lobes via lobar or secondary bronchi. Now, the lung is covered by what is called visceral pleura, while parietal pleura covers the pleural cavity. So this pleura secretes fluid that lubricates the lungs. This fluid, serous fluid, fills the pleural cavity, and that the pleura covering and fluid in the pleural cavity allows the lungs to expand and contract without being damaged. Each lung has a lot of terminal bronchioles, and each bronchiole supplies individual bronchopulmonary segment. So that's a bronchopulmonary segment that contains a bunch of alveoli. And the function of the alveoli is the gas exchange between the blood and inhaled air. Alveoli are formed by the simple squamous epithelium And you can see that each alveolus is surrounded by a dense network of blood vessels. So the walls of this alveolar sacs, as they called, contain alveolar cells from the capillary, which makes those walls very thin. It's called the respiratory membrane. So here you can see the respiratory membrane being formed by the cells of alveoli, simple squamous cells of alveoli, and simple squamous cells from the blood vessels. Septal cells inside of the alveoli, or so-called type 2 alveolar cells, they produce surfactant. Surfactant is essential to prevent alveolar walls from collapsing, since they can stick to each other. So if we would not produce surfactant, alveoli would collapse after each exhalation. The function of detergent essentially is to reduce surface tension in alveoli and allow them to expand easier. Inside of the alveoli are alveolar macrophages, which remove the particles that we inhale. And the gases in the alveoli diffuse across the respiratory membrane, which consists essentially of the alveolar cells, basement membrane of the alveolin capillary, and endothelial cells of the capillary. So this is an enlarged illustration of the respiratory membrane. You can see type 1 alveolar cell, type 2 alveolar cells that produce surfactant. You can see that the respiratory membrane is formed by the type 1 alveolar cell, the basement membrane, and the endothelial cells of the capillaries. In the alveoli, oxygen diffuses from the alveoli to the blood into the pulmonary capillaries, while carbon dioxide leaves the blood in the pulmonary capillaries and gets into the alveoli. So basically, the lumen of the alveolus is filled with air. Now, you may ask, what happens in the systemic? This process right here is called external respiration. Now, you may ask, what happens in the internal respiration? In the internal respiration, in the systemic capillaries, oxygen diffuses from the blood that is in the systemic capillaries. Oxygen diffuses into the tissues. Carbon dioxide that is in tissues diffuses from the tissues into the blood that is in the systemic capillaries. So let's talk about pulmonary ventilation. So pulmonary ventilation is the process that is governed by the Boyle's law. With the increase in volume, pressure in that volume decreases, and with the decrease in volume, pressure in the volume increases. So basically, during inhalation or inspiration, diaphragm and intercostal muscles contract. That contraction increases the size of the thoracic cavity, which increases the volume of lungs. Increased volume of lungs means that the pressure within the lungs decreases and air rushes in. During exhalation, diaphragm and intercostal muscles relax. That reduces the volume of the thoracic cavity. Reduced volume of the thoracic cavity increases the pressure, and that means that air is rushed out of the lungs outside. So this picture illustrates several pressures that are associated with the lungs. In alveolar pressure, or intrapulmonary pressure, is shown here. It's a pressure in the alveoli. Intrapleural pressure is the pressure in the pleural cavity. and it's always lower than intrapulmonary. So intrapulmonary pressure is higher than intrapleural. When people inspire, alveolar pressure, due to the increased volume of the lungs, reduces, becomes lower than atmospheric pressure, and air is flowing from atmosphere into the lungs. During exhalation or expiration, lungs become smaller. That increases alveolar pressure, so it becomes higher than atmospheric, and air is rushed out of the lungs. Now, it's really interesting what happens when intrapleural and intrapulmonary pressure become equal. In the case, for example, if chest is penetrated by a sharp object and atmospheric air rushes into the pleural cavity. If alveolar or intrapulmonary and intrapleural pressure become equal, lungs, due to their natural elasticity, will collapse, and this is called pneumothorax. Respiratory rate is governed by medulla oblongata and pons. Respiratory center in the medulla, that consists of ventral and dorsal respiratory groups, controls normal rhythmic contractions of the diaphragm. You can override this normal respiratory rhythm by the brain. You can hold your breath, you can breathe faster, slower, and whatnot. Now, pons modifies these patterns in order needed. For instance, when you speak or when you sing, pons will provide some modifications. Now, what controls, what influences the respiratory rate and depth? Three main parameters that affect respiratory rate and depth are carbon dioxide, pH, and oxygen. Elevated carbon dioxide, low pH or acidosis, and low oxygen all increase respiratory rate and depth. Out of these three, carbon dioxide levels are the most important. Low pH is the second important, as low oxygen is the least important factor that increases respiratory rate and depth. Now, human breathing can be characterized by several respiratory volumes. Tidal volume, here shown in yellow, is the volume of normal breathing. Now, inspiratory reserve volume is the volume that can be inspired on top of the tidal volume. Expiratory reserve volume is the volume that can be expired after normal tidal exhalation. Residual volume is the volume that is left in the lungs after the forceful exhalation. Now, those were volumes. Now, the capacities. Total lung capacity is the total volume of the lungs. Vital capacity is 2 reserve plus tidal volume. No residual volume there. Inspiratory capacity is the tidal volume plus inspiratory reserve, and functional residual capacity is expiratory reserve volume and residual volume. Now, let's talk about the Dalton's law. So the Dalton's law governs the movement of gases because gases move following the pressure gradient. Here you can see that in the alveoli, the pressure of oxygen is higher than the pressure of oxygen in the blood that's present in the alveoli. So in the alveoli, oxygen will move from the gas, from the alveoli, into the blood. The pressure of carbon dioxide is higher in the blood than in alveoli, so carbon dioxide will move from blood to the alveoli. Now in the tissues, partial pressure of oxygen in the capillaries, 100, is higher than the partial pressure of oxygen in tissues, 40. So the oxygen will move into the tissues. On the other hand, the partial pressure of CO2 in the tissue is higher than the partial pressure of CO2 in the blood, which means that carbon dioxide in systemic capillaries, carbon dioxide in tissues, will move from tissues into the systemic capillaries to be carried away. So here is the illustration of what happens in the external respiration, what happens in the lungs. Now I want to reinstate that gases move independently. So diffusion of oxygen does not influence diffusion of CO2 and vice versa. This summarizes what we were just talking about, that oxygen moves from the alveoli into the blood, while carbon dioxide moves from the blood into the alveoli. And the driving force, of course, is the difference in the partial pressures. Now, in the internal respiration, as you can see, as we already mentioned, carbon dioxide from the tissues diffuses into the blood, while oxygen diffuses from the blood into the tissue. Okay? So the gradient that is formed either in the alveoli or in the tissue allows the respiratory gases to enter the cells or leave the cells without requiring the energy. Now, why CO2 partial pressure in the tissues is higher? Because cellular respiration produces carbon dioxide, and that is why carbon dioxide constantly accumulates in the peripheral tissues and is ready to diffuse into the blood. Now, hemoglobin in the red blood cells carries oxygen. That's the function of hemoglobin. It consists of the protein component called globin, and inside of the globin, so that is hemoglobin, consists of 4 subunits, alpha and beta. Inside of each subunit is the molecule of heme, and inside of each molecule of heme is molecule of iron. Oxygen binds to the atom of iron in the molecule of heme, which in turn is attached to the globin subunit. So oxygen binds to iron. Obviously, it can carry 4. One molecule of hemoglobin can carry 4 oxygen molecules, and hemoglobin will carry oxygen from the lungs to the tissues. Hemoglobin is also critical for the transport of carbon dioxide. We will talk about it. It carries about 20% of total carbon dioxide. Now let's take a look at this curve that I have here. It is called hemoglobin dissociation curve. So when oxygen pressure is high in the lungs, basically, the amount of oxygen that is bound to hemoglobin is maximal, 100% basically, saturation. Now, as the pressure of oxygen decreases and becomes characteristic of it for the tissues, the saturation of hemoglobin with oxygen goes down. Only about 75% of possible available positions for oxygen on hemoglobin are actually occupied by oxygen. So the difference between 100 and 75% is the amount of oxygen that is unloaded in the tissues. Now, if you would look at these two curves that show hemoglobin dissociation curves, you will see that when pH goes down, tissues become more acidic, or as temperature increases, tissues become warmer. The hemoglobin dissociation curve shifts to the right, which means that as temperature increases, the unloading of oxygen from hemoglobin into the tissues increases. More oxygen gets delivered to the tissues that are warmer, and more oxygen is delivered to the tissues that are more acidic, which is normal because slight acidity and increased temperature are characteristic of metabolically active tissues, which explains higher oxygen unloading from hemoglobin into the tissues. Same is true for decreased oxygen saturation in tissues, but as we mentioned, that's the least important factor. Now, carbon dioxide is transported back to the lungs from the tissues by several routes. It can be directly dissolved in the plasma. It can be carried as bicarbonate anion in the plasma and red blood cells. And also CO2 can bind to hemoglobin, forming carbaminohemoglobin. What I want to highlight is that carbon dioxide, when binds to hemoglobin, does not bind to iron. It binds to the protein component of hemoglobin. Now let's talk about some upper respiratory tract diseases. Sinusitis. You have sinuses that the cavities lined up with the mucous membrane. When they get inflamed, they get filled with mucus, with the secretion, usually caused by viruses or bacteria. Basically, it's a very, very bad stuffy nose because sinuses drain into the nasal cavity and you have this mucus occupying those spaces. Pharyngitis is inflammation of pharynx. Strep throat is caused by Streptococcus pyogenes. Bacterial infection can be severe if it's untreated. Diphtheria is another pharyngitis. In diphtheria, pseudomembrane made of various blood cells and dead bacteria is formed in the throat, can obstruct respiratory passages and lead to suffocation and death. Fortunately, this is the vaccine preventable disorder. Tuberculosis is the bacterial infection of the lungs caused by Mycobacterium tuberculosis. Symptoms of the chronic one: fever, night sweats, cough, green or bloody sputum, can be treated by the long course of antibiotics. Lung cancer, several forms from less to more invasive. 90% of all lung cancers is the result of smoking. You can see here is men started to smoke less. The rate of lung cancer in the American males decreased, while women started to smoke more, and the rate of lung cancer incidence in females actually went up. Really hard to detect. You can see the cancerous mass here. It's pretty bad. Early detection is the key. CT scan or X-ray. CT scan is better. Without metastasis, cancer can be surgically removed. If it metastasizes, radiation and chemotherapy increase survival. Now we have few new therapies that actually won Nobel Prize 1 year ago, I think. Reactivate your T cells, your immune cells, so they can kill cancer cells. They can help. Therapies can help. We're not talking about cure. We're talking about an increased survival. Now, lung diseases can be obstructive. It can be constrictive. So an obstructive pulmonary disease, normal flow of gases into the lungs is obstructed by something. So here you can see some examples of obstructive disease: emphysema, chronic bronchitis, and asthma. Okay, in emphysema, you can see that alveoli get destroyed. That leads to labored breathing, air hunger. Frequent pulmonary infections due to the poor ventilation, hyperventilation and hypoxemia, respiratory acidosis, kidney failure. So when alveoli destroyed in emphysema, people try to breathe harder, which leads to exhaustion and flattening of diaphragm, which actually reduces ventilation. Damage to pulmonary capillaries leads to the right side cardiomyopathy and systemic edema, the stuff that we talked about in cardiovascular. Chronic bronchitis leads to chronic bronchial inflammation, accumulation of mucus in the passages, obstruction of the airways. Now, asthma is the reversible chronic obstructive pulmonary disease. And generally speaking, for chronic obstructive pulmonary disease, there are two components: emphysema, damage to the alveoli, and chronic bronchitis, obstruction of the respiratory passages with mucus. Now, asthma is often considered to be a constrictive pulmonary disease because in asthma, respiratory passages constrict as the result of the bronchospasm. Now, we never mentioned pneumonia. I wanted to say a few words about pneumonia. I don't think we have it here. So pneumonia is the inflammation of the lungs, bacterial or viral infection. It leads to accumulation of fluids so that gas exchange across the respiratory membrane is reduced. The main factors that contribute to the development of emphysema, lung cancer, chronic obstructive pulmonary disease is smoking and air pollution. Now, the last bit about respiratory system I wanted to talk about is cystic fibrosis, which is obstructive pulmonary disease. So it is caused by accumulation of abnormally viscous mucus in the respiratory passages. There is an abnormal chloride channel, abnormal gene for chloride channel in the membrane of the cells in the respiratory passages. This leads to the accumulation of mucus. As we mentioned, accumulation of mucus leads to frequent bacterial infections. It may affect lungs, pancreatic ducts, reproductive ducts. Treatments are mucus dissolving drugs, chest percussion, inhaling hypertonic saline, antibiotics prescribed for infection. The treatment, sort of the cure, is the lung transplantation. The problem is that two bacteria, Pseudomonas aeruginosa and Burkholderia malii, they may remain in the upper air passages and may lead to secondary infections after the lung transplant. So overall, it's a pretty terrible disease, which greatly reduces the lifespan of the people that are affected.